Hi, Dr. Lee.
Hi, Daryl.
Hi, thanks for being part of our conference today. Could you tell our audience what you do and where you do it?
I am a radiation oncologist in British Columbia working in BC cancer. My main focus is head and neck cancer, prostate cancer, and skin cancer, but prostate cancer is my main research interest at this point.
Right. And you're a gay man, you're completely out to your patients, to your friends, family, etc.
During my training, even as a medical physician, as a student, it's very difficult to come out to the classmates. But during my residency and right now in full practice, yes, I am gay man. If people ask me, I will say that. Yeah.
Great.
Yeah.
So when patients come to you, how do you let them know or make them feel comfortable to be out to you?
It's actually a difficult thing because I cannot openly say that I'm a gay physician without some context. It's very fortunate that in the cancer center that I work with, there is a questionnaire beforehand that asks patients how do they identify with themselves and the relationship and orientation. So I can get a hint there, but there are still patients that decided not to answer that question. My question usually is very general. If they're alone, I'll ask them, do you have a partner? Any significant other? I leave the gender out. I leave it for interpretation. If they want to volunteer that information, that would be fine. If not, then that's okay.
Yeah. So what strategies do you think gay patients and bisexual patients should use when approaching any doctor around prostate cancer to sort of start the conversation that they're gay men or bisexual or men who enjoy sex with other men, and they want to know the impact of treatments and care on their lifestyle?
I have to say, even till today, it's very difficult for patients to do so because they can find a doctor with good reputation only when they encounter that physician, know that he or she may not be comfortable with dealing with a gay patient. It's actually still happen in my cancer center, in other cancer center, but I think this is important to patient to be honest to the physician. If the physician is not comfortable with it, or you feel that the physician is not comfortable with it, then they can actually request and probably should ask for a second opinion. And hopefully they can be referred to someone that is more comfortable dealing with a gay and bisexual patient. But I don't think as a patient, I know it's scary. It's like coming out again. But I think you still should try. And most of the doctors nowadays are comfortable. There will be a few here and there, but most of them are comfortable.
Let's try and ease that struggle a bit, because we have an audience of, a couple of thousand men who enjoy having sex with men. Pretty much everyone that's watching this has already been diagnosed with prostate cancer, but they're wondering, how radiation therapies impact is going to impact or already has impacted their lives.
Yeah.
So in general, what does radiation do to a prostate cancer patient that might affect like anal receptive sex?
Okay. So first of all, most of the side effect from radiation would be on the rectum. You're correct. But that's also different, depends on the technique of radiation that you use. If you use external beam radiation, then yes, there will be more radiation to the rectum. But with radiation treatment, there is new advance, there is SABR. And with SABR, there is more a smaller margin around the prostate that you target. So again, less radiation to the rectum. And there's also new technique by inserting something called space OAR that kind of crank open the space between the rectum and the prostate that give extra protection to the rectum. Or if you use brachytherapy, then most of the side effect actually is on the urination. The rectal side effect is not that common with the brachytherapy, at least not as common as the external beam. So now with the let's just talk about external beam radiation to the rectum. So with the radiation, during radiation there will be inflammation. So there will be discomfort, sensitivity in the rectal area. After radiation, it becomes a more chronic process that there will be fibrosis and scarring. So with scarring, I tell patients that your tissue normally is very flexible. It's like a balloon, like a tube that you can expand, contract. But the area that has been scarred, they cannot do that as well. So with any kind of stretching, there can be pain, and in some cases there can be bleeding. So for theoretically, with the radiation to the rectum, there potentially can be difficulty with receptive anal intercourse if there is significant scarring, if there's significant bleeding. But every patient is different, and we don't have study to say how much you're actually impacted by that scientifically. Like we cannot say that patient experience is worse by how many percentage point. You don't have those information. And some patient can, after radiation, give a few months to recovery and then try and see how it goes. I think that's the best way to approach it.
So when you say scarring, what is the scarring of anal scarring actually feel like to the guy who has it? I mean, is it lumpy and it's going to rub and abrade, or what?
The scarring is not like you have a skin scar that you can see. It's more like the tissue. The tissue is more tense and taut, like you cannot quite stretch it. But it's not like a visible lump of scar that you see on the skin surface like that. No.
Okay. And it never goes away?
No. So I'm talking about the difficulty with the logistic, the physical aspect of having the anal intercourse. But the actual organ potentially gets stimulated would maybe be the prostate gland or the neurovascular bundle, like behind the prostate gland. And those may or may not be affected by radiation. And if they were affected by the radiation, it may not manifest right away. It may take some time to manifest. So patient may not notice any difference immediately, like if they're capable of having the anal intercourse, but after a while, they may notice some change. Yeah, that's why I say it's case by case basis, and it's technique dependent. And also when you deal with radiation oncologists, some people would prioritize treating the prostate gland. Some people would put more constraint, more restriction on the normal tissue organ. Depends on which one they want to prioritize, which one they want to optimize. So different oncologists, even though theoretically we treat the prostate cancer the same, we actually can have quite different aggressiveness. Quality of life is really important. But at the same time, if the prostate cancer is not treated successfully because you're trying to protect normal tissue, then the prostate cancer will recur. And if the prostate cancer recurs, surgery is horrible after radiation. Then the next option will be androgen deprivation therapy, which would have much more side effect on sexual function than radiation side effects. So you do have to make the call as a patient, unfortunately, that cancer come first or quality of life come first. Radiation can cause fibrosis, can cause healing difficulty, can cause proctitis in the rectum, and all of this can affect the ability to have the physical act of the anal intercourse with the penis into the rectum, because as you imagine, the tissue is not as not as flexible, not as resilient, and potentially there can be pain, there can be bleeding with the anal intercourse. that is the physical aspect of the sexual activity. But regarding the actual pleasure of the experience of the anal intercourse, and I have patients that after radiation treatment can have very good anal intercourse with no bleeding, no pain, everything as normal. And I have some people that have erectile dysfunction after radiation, and they can no longer be the inserted partner, and they switch to the anal receptive role, and they fulfill that role perfectly as well. So there are situations that I would say you would have to try after the treatment to listen to your body, to accept that there will be a little bit of difference, but it may not be all bad. It may still be enjoyable.
Yeah.
So that's also mean that even physician, as a physician level, which is a shame that we're supposed to be respect all parts of human body, all body function the same, but somehow the part regarding sex, which is very important and pleasurable, there is not quite, lack of a better word, clear, vigorous research that has been done. Maybe because there is an inherent hesitancy from the medical field part that we didn't really put as much effort on it. Like when you come see a doctor, health comes first, life expectancy comes first. Only in the last 20, 30 years, we start looking at, okay, patients survive now. How do they live? And each time you ask a question in science, it takes another 10, 20 years to answer, because you need time to do the research, you need time to collect data, you need time to validate them. So that field is lagging behind, and unfortunately the patient suffers. Like we have good advance in prostate cancer treatment, actually treating the cancer, but whether we can make patients actually live better after the cancer, or if we cannot make them live better, can we help them cope better? I don't think we are quite there. We're lagging on that.
Yeah.
Mm-hmm.
Does brachytherapy, which is seed therapy, impact sexual pleasure in a different way?
Again, this have not been answered. That's actually what I'm trying to answer with my research, because no one can actually say nowadays and tell you for certainty that surgery, brachytherapy, saver, external beam radiation, even some people pursue chirotherapy or HIFU, all the other treatments that they want to try. No one can say that which one is better for what sexual function. We don't know as well. So it's hard to answer at this point.
Yeah. Let me ask a couple of quickies that men want to know. So a man's completed a course of, let's say, external beam radiation. They've used stereotactic radiation, so it's like, 5 or 6 days of therapy. How soon after that's completed can they be anal receptive partners? How can they even get pegged or anything like that?
So, again, you have to play it by ear. I would say probably give it at least 3 months, maybe 6 months, and depends on the size of your partner. You may want to be gentle. You may want to use smaller diameter, like finger. There are lots of toys that's available. Step by step. Try to think back when you first came out, how you prepare for your first anal receptive intercourse. Like you don't go right ahead you don't go right ahead and choose. Let's say for patients that like to, for gay men that like to use toys, for example, they don't go right ahead and pick the biggest one possible. They ease themselves in and they start to learn the process when they're coming out. So after prostate cancer treatment, give a few months for healing, and gradually try it again, smaller diameter, see how you tolerate it, short amount of time, see whether it's still pleasurable, notice the difference in the pleasure. And it may feel different, but if you give it a chance, feeling different doesn't mean it's feeling bad.
Mm-hmm.
So
Right.
you do have to try, you do have to experiment, but not trying it and be too afraid. I think that's the wrong approach. Only after trying, if it is not successful, too much bleeding, too much pain, if it happens, you get scared, then wait a few months, try it again. What I don't want people to do is to set themselves up for failure. Because if they try something right off the bat, go the strongest intensity to try, and it failed, then then the next time they try, they will think that it will fail again. Like, for example, for I have men that have erectile dysfunction, and they try different medication, doesn't work. They try the injection, and with COVID, people do injection. People do teaching with the injection to the penis through video conference. And instead of a nurse actually show you how to do it. And it didn't work. And the patient gets frustrated and think that it doesn't work. I say, like, okay, pandemic is lifted, lots of the restriction, go learn it properly and give it a real fair try before thinking that it will not work for certain. So put yourself in the most favorable situation, highest possibility of success. Of course, you have to be comfortable, have to be in a calm, quiet environment, and try to get as much pleasure as you can, or as tolerable as you can. Just ease yourself into it. I think that's the best advice I can get.
Yeah, very good. With brachytherapy, though, there's a different consideration, isn't there?
Brachytherapy is a different story, you're correct, because the radiation is slowly dissipating. It may take longer than the typical 3 to 6 months. There can still be inflammation that's happening after brachytherapy. But on the other hand, most of the radiation dose with the brachytherapy, the effect is more on the urinary function, not so much on the rectal function. At the same time, you probably don't want your partner to be poking around the prostate with the brachytherapy seat while you're still kind of receiving the treatment. So that one you do have to wait. And I think different institution is different regarding the wait time, how long they should wait after the procedure, because they do different centers, they use different technique. Again, like I explained before, with radiation, external beam radiation, the radiation therapist, the radiation oncologist can plan the prostate and the dose distribution to the rectum differently, and the therapist will follow through. Different centers had different brachytherapy technique. Actually, they all say they're going to give certain dose to the brachy, but how generous they actually do it, different, very different actually. There are centers that is very aggressive in brachytherapy and cover lots of area around the prostate. And those have good control rates, but potentially higher side effects, for example.
Right. So does it make sense actually for patients to shop around from center to center, asking, how aggressive their therapies are and the impacts on quality of life?
Like I said before, I think cancer care still come first. I think you should at this point it's too early to pick a treatment based on your sexual quality of life. It's too early for that. You still need to focus on getting cancer treatment first. Or you can, unfortunately for the patient that currently dealing with prostate cancer, there is no data that can guide them. In a situation that there's no data to guide them, then you should focus on things that you can control and things that you can know, rather than try to make a big decision based on unknown and hypothesis.
Right. Follow data and know that the worst quality of life is when you're in a casket or,
Yeah, and like I said before, if you opt for a lesser treatment, when you should have a more aggressive one, then the long-term outcome may mean the biochemical recurrence with the prostate cancer. Then you need to be on androgen deprivation therapy, and there go the libido, erectile function, decreased muscle mass, weight gain, all of those things that affect sexual quality of life.
Sure. Ejaculate. Ejaculate disappears after therapies regardless, correct?
Some people have a little bit left. Some people after radiation treatment will have a small amount of ejaculate, but over time it will dry it up. And it does affect the sensation of the orgasm.
Yeah. And the idea that men, like, I mean, you've followed men a couple of years after therapy. Do you find that they're satisfied that they saved their lives, or that they regret that they impacted their quality of life? What's your sense?
I think the first question is still, what is my PSA? That is still the first question, not, doctor, when is my sex life going to get better? So from that, I think patient is still focusing on the prostate cancer first, which is, like I said, probably the right approach in the absence of more believable data at this point. So the prostate cancer, get the treatment, that's the standard of care. But then the next question will be the sex. That, doctor, is there anything else I can try? I try Viagra, I try Cialis, I try injection, should I go for the implant? It seems very aggressive, should I do it? Like those come. And or some patient just plain gave up and they didn't try, they didn't think they can. Like some people think that, oh, if I have lost my erection, that means I cannot have an orgasm. That's not true. You can still stimulate with a flaccid penis, you can still achieve orgasm. And I have men that reported that orgasm, yes, is different, is not as intense. They actually describe it as a more prolonged, diffuse, but is very pleasurable still. So like sexual satisfaction can be had after treatment. You just have to be open-minded that knowing that there will be some difference. It won't be the same as before the treatment. But if you're willing to try, you can get some form of satisfaction from it.
Right. And it doesn't change your identity as a gay man. I mean, what do you, go ahead, tell.
That's hard to say, because like, unlike straight men, like the role, like a man or woman, the penile vaginal intercourse, that role is very defined. With gay men, there's the top and bottom, whether it's cultural, whether it's psychological. For top that lost the erectile function, that also goes with the confidence that they have when they are with other men. And before the treatment, they may be very confident, they may be a very good top, but now suddenly they lost the erectile function. How do they feel? And then, am I a bottom now? And then that would change the identity. That would change how they feel, actually. Like the dating is very different, I would imagine, after prostate cancer treatment. And many men are single, like as straight men, but more so for gay men. When we get older, many of them do not have a partner, and which is fine. But then on top of that, if you lose your sexual function, that's not quite fine. That is very difficult. Yeah, identity would be affected, actually.
So let's talk a bit about how we're moving the science forward and our understanding. What kind of research have you been doing around sexual and gender minorities and prostate cancer?
It started when I was a resident in training for radiation oncology, and I was following my mentor, and he was interviewing prostate cancer patient, and I was listening to that and say, oh, that's all you talk about, sex. Then I suddenly think, okay, I have a partner too. What happened if he got prostate cancer? How would I advise? What would the sex life would be? So I immediately go on PubMed. I was like searching for articles, and that's many years ago, by the way, and there was nothing. There's actually one research that was done a long, long time ago. And that research actually stopped because the recruitment was very poor. And I say a long time ago, I think it was more than like 40 years ago. I realized that there's actually no good research done on quality of life for gay men with prostate cancer. And any kind of quality of life, you need a good measuring tool that's called a validated questionnaire. And what happened is that most of the quality of life data is collected using something like EPIC, for example, and it's based on predominantly heterosexual population.
EPIC
Yeah.
is I forget actually what EPIC stands for, but
Yeah.
it's what in the field in the trade
Sorry.
we call a survey instrument,
Yeah.
which is like a bunch of questions that have been tested with a bunch of patients, and to the best that we can, we know that the answers reflect the actual real world experience of these patients. And so we would give like the EPIC survey, which I think has 37 questions, and it's long form or something like that.
It's a long, there's a short form.
Yeah, to patients. But as you say, it's basically heteronormative. It's focused on heterosexual behaviors and such.
Sorry, thank you, Daryl, for doing this explanation, because you asked me about my research, I get excited. Let's step back a little bit, talking about what I mean by validated questionnaire. So it is an instrument with different questions to probe different aspects of the topic of interest, for example, sex in this case. Because if you just randomly ask patient, each physician, each nurse may talk to the patient differently, use a different tone, the wording is different, and that subtle difference can change how a patient answers those questions. So it's not standardized, and without a standardized question, you cannot get a standardized response that you can compare. So having this validated questionnaire is like having a ruler for measurement. You have the centimeter, okay? But the problem with the existing questionnaire is that it's mostly generated by collecting response experience from heterosexual population. So what I describe this existing measurement tool as a straight ruler. It's unbendable, it's not flexible, it's focused on one thing mostly, erectile function. That is not what gay bisexual men need, because our sexual practice is more variable than just erectile function. What about ejaculation? What about, we talk about insertive, receptive anal intercourse? What about blowjob, for example? Do you ask about that? And those are important things for gay men. And with this such a rigid and unidimensional measurement, you cannot reflect, you cannot advise, you cannot monitor the sexual experience of gay men before and after treatment. So my research is different from ground up, is that we collect response from only gay bisexual prostate cancer patient after treatment, surgery, radiation. We listen to the common experience afterwards. What's the side effect they experience? What is the concern? And what changes they experience? And with that, we compare to existing questionnaire, and we also identify area that we think may be important to gay men. And then we generate that questionnaire, and we go through the process of validating it basically in the last part, so that we can create a tool that is, instead of a straight ruler, it will be more like a measuring tape that is flexible, that can tailor for different patient for their needs. So that's what I'm trying to do. And with this tool, I hope there will come a time that with enough data, it can help the gay man to decide, okay, or expect what side effects they would get from what treatment with more accuracy. Not necessarily mean that they can, again, not necessarily mean that they can base their treatment decision on quality of life, but more have knowledge before the treatment and that help you prepare and cope. Study has shown that the main regret for patient is sexual side effect after prostate cancer. But that's also come with unpreparedness, because during the initial consultation with the patient and physician didn't ask, patient afraid to ask, not much education going on, no clear answer, treatment over, then you suddenly think, what have I lost? What have I done to myself? At that point, you're already a step behind in your mental preparedness on how to deal with the side effects. I think have the knowledge right off the bat would help. Maybe it doesn't help physically, but it will help psychologically.
Yeah, great. Well, we hope everyone that's listening will consider participating in this new phase of developing this critical instrument. Dr. Lee, thank you very much for the care you show your patients. Thank you for being out and the courage that you've displayed in doing that during the course of your career. And thank you for being a colleague and friend to our Malecare community, and for welcome to our conference and our faculty.
And thank you very much for giving me this opportunity to talk to you guys, and thank you for all the support in the past. Thank you.